Hello everyone. Thank you for being with us tonight for the second episode of PCR London Valve live from London. It's impressive, we are already at the end of day one and it has been such a long day. Lots of news, lots of discussions, lots of learning especially. So now I'm here with my guests. Here we have already Valeria who is here, and we're going to go through the program and we'll give you some glimpse of what happened rather on the valves, on the late valve tracks, late breakers, hotlines, and we will end with an expert interview. So we'll start with you, Valeria. Thank you for joining me.
Thank you. It's a pleasure being with you today. We'll go through two important late breaking trials.
So what you got for us? I guess we start with the Tricuspid, right?
Yes, exactly, in your honor. So Stefan Windecker presented today the one-year results of the feasibility TRISCEND study, so transfemoral transcatheter tricuspid valve replacement. 176 patients with functional or degenerative tricuspid regurgitation with a grade higher than moderate, and either sign or symptoms of tricuspid regurgitation or prior heart failure hospitalization, despite optimal medical therapy, were enrolled in this study. 88% of patients had a TEER grades higher than severe. And the intervention was indeed replacement of the tricuspid valve with bioprosthesis EVOQUE. The device success was 94.4. The mean time of the procedure from the delivery system insertion to removal was 71 minutes on average. It was, of course, a single-arm open-label design trial, and very interesting outcomes of the study. First of all, as a strength of the study, I want to say that the study had an echocardiographic core lab. So the core lab adjudicated significant reduction in TR, and in particular, 98% of patients had lower than mid tricuspid regurgitation, while 79% had absolutely no trace of tricuspid regurgitation. And also when we look at the clinical, functional, and quality of life measurements, we actually saw a significant improvement of all the scores. So New York classification, 93% of patients were in class 1 or 2 New York heart. QCCQ improved by 26 points. The 6-minute walking test increased by 56 minutes. So important result. As well, the cardiovascular mortality was 9.4%. These results were 1 year follow-up, and the follow-up of 1 year was achieved in 149 patients. It's important to say that this result, actually the reduction of tricuspid regurgitation persists after 1 year. So this is an important take of the study. We'll have a follow-up up to 5 years, and there's also a TRISCEND 2 randomized control trial underway.
Thank you. Very impressive results, huh? So you've been in the room, I guess?
Yes.
What were the main discussions? I guess there should be something around the right ventricle.
Yeah. Very good. Indeed, there was a question about the TAPSI, and the TAPSI actually did not improve, while the volume, the right ventricle volume, actually diminished, and that's an important, actually really important marker of prognosis on long term. So I think the discussion was about which is the most reliable, right ventricle measure that we have to take into account, and probably we have to await a longer follow-up to say something about right ventricle remodeling.
But I guess from what I hear from you, TAPSI did not improve, but it did not decrease neither.
Exactly.
And this was my main concern.
But
so it's
probably it's because indeed the TAPSI is not as reliable after the implantation of bioprosthesis as we measure before the procedure. That's the thing.
Absolutely.
Yeah.
So very interesting for the tricuspid.
Yeah.
What about the aortic valve?
Yeah, there was also a really interesting late-breaking trials, and Dr. Andrea Scotti presented the hemodynamic performance and clinical outcomes of the self-expanding ACURATE Neo 2 device. So the patients undergoing transfemoral TAVR with ACURATE Neo and Neo 2 devices, and actually from observational registry Neo Pro and Neo Pro 2 were enrolled, and with a mean age population with a mean age of 82 years old, 66% of female. So intervention was indeed ACURATE Neo 2 device. It was implanted in 763 patients. So what are the engineering requirements of the new device? Why do we need to study the new device? We know that from scope 1 and 2 randomized control trial that one of the major issues with the ACURATE Neo previous generation was indeed the paravalvular aortic regurgitation. The concept, the engineering concept about the ACURATE Neo 2 is that the outer skirt, which is higher and increased by 60% as compared to the previous generation, may actually adapt better to the anatomy, especially to the challenging anatomy and calcified anatomy of the aortic valve. And also important, the expandable introducer, which is 14 French compatible, and also a radiopac marker, which actually helps the positioning of the valve. The control consisting in the ACURATE Neo, so 1,263 patients. And the major results of the study were indeed a mother of severe paravalvular regurgitation, dramatically reduced in the ACURATE Neo 2 arm, so a significant reduction. And also especially these results were mainly found in the aortic valve with a higher grade of calcification. So these were results up to 12 months, and probably we will have, these are observational data, we will have some confirmation of these results in the future.
Thank you. So can you give us more comments on what was happening in the room? What were the critics or the discussions?
Interesting, you know, Professor Tamburino from Catania, he was one of the PI of the scope. And so his comments was about the consequential time period of the two generations device. So we're talking about indeed two time periods. So the question is, on one side, of course, this device has improved a lot. So we have like important engineering refinements. On the other hand, we have to also focus our attention on the operator experience, which has developed, we hope, in the course of the time, and also like implantation technique. So, for example, the use of the cusp overlap view, more like, which is broader now than it was probably with the earlier generation device.
So it's not only about the device, it's also about the operator, as usual.
Exactly.
Okay.
Exactly.
So thank you, Valeria.
Thank you,
As you
Nicole.
see, we are trying to give you as much as we can some insights from inside the room, so that you have the feeling that you have been with us. But I mean, it's really impressive to see what's happening here. The rooms are crowded, they are fully packed, and there are lots of discussions that we have. So now I will move to my next guest, Alessandro, who has joined. Hello,
Hi,
Alessandro.
Nicole.
Alessandro has been spending his time in the simulation lab, and I don't know how you managed to get in. I mean, it's fully packed. It's very nice to see how people are very attracted to this kind of learning, right?
Yes, really a great feedback actually. The room is fully packed. Lots of sessions going on. I think this really gives you the feeling of how much simulation-based intervention will be the future of training. And in this sense, I think that PCR London Valve is really a cutting edge of education. I learned a lot today. It was really a great experience, warmly recommended. Actually, the structure of the simulation lab is based on 3 principles, which are essentially the learning sessions, the workshops, and finally the training village, where the idea is actually to give you the chance of learning from the experts, then practicing in the small groups, and finally get your personalized hands-on experience in the training village. There are 3 tracks that you can follow, aortic, mitral and tricuspid, and today I decided to follow mitral and tricuspid, and I actually have to say that I learned a lot. really impressive. We started with some learnings of the anatomy, a better understanding of the anatomy using some specimens, either pig hearts or some models like this one that I brought to you.
Oh, I was scared you were going to say that you have a
No.
pig heart in here. Okay.
No, this is a 3D printed model. Really helps you to show the anatomy, to understand the complex anatomy of tricuspid valve, these apparatus, and also the mitral valve. And really, we've been using these models today to get a three-dimensional perspective on the complex anatomy of these valves and to understand even the way that devices interact with this anatomy and how to assess these using currently available imaging modality. I mean, echocardiography and computer tomography mainly. And this is really eye-opening because you can really see how this device interacts with the anatomy, and then you can move on to test the way they work on a simulator. And this way you will really have a perception and understanding of how each thing that you do is producing something into the simulator. You can really understand every movement. You really take your time to get confidence, really get used to the device. I think that this in the future will really help you performing procedures in real patients in a safe way.
So did you get the chance to use the simulators?
Yes, of course. It was very nice, actually a really nice hands-on experience. I think the level of details that these simulators reached is really impressive. You can actually see that leaflets moving, you can actually even simulate the transesophageal echocardiography with a real probe and a real echocardiographer, because you know these are complex interventions on these valves and you really need to have a three-dimensional understanding of the anatomy and the way to assess how your device is interacting with it.
Yeah, I passed by the learning room yesterday and I was impressed to see how realistic this looks. I mean, you look at the echo and you cannot tell this is only a simulation, this is not a real heart.
Yes.
I mean, it's impressive.
It's impressive. I think it's going to be the future of training and education. And this will give you the chance to really stop, take a deep dive into what you're doing, understand everything, even complications, understand everything, and then be ready for your interventions in real life.
Start your complications with complications on the simulator. I've killed some patient on the simulation lab. And it's important to kill the simulation and not the patient.
Yes. Great experience.
So you're going to stay a few days in the simulation lab?
Yes, of course. I think I will spend some other days here in the simulation lab, and tomorrow probably I will be following the aortic track, where there will be some interesting talk about coronary access after TAV. You know, it's a very hot topic, so seeing these things through the simulators will really enhance the way you understand it and the way you can really practice better for your patients.
So I guess our guests will have to stay tuned if they want to see tomorrow more about the aortic valve. We'll be happy to have you here tomorrow for more discussions.
Thank you.
So thank you, Alessandro.
Thank you very much.
Thank you for bringing your not a big heart. And now we will move to the next sections. We also had people today spending time in the dedicated valve tracks. So I don't know if you followed. We have the sections. The conference is made like separate tracks. We have the aortic, the mitral, and the tricuspid track. And now I have been joined with Cara and Jonathan, who have been spending time in each of the tracks and who will give us inside stories from what was happening there. Thank you for joining. How are you doing? So Jonathan, maybe I will start with you. So you were in the tricuspid side, right?
Exactly.
What did you get for us?
Today I attended on this tricuspid track a nice session on repair versus replacement, giving actually a nice glimpse of this whole field, where it stands, where it came from, and also where it might be evolving to.
So, can you tell us more? What should we expect?
Sure. So the session started with like a device potpourri talk, the whole device parade given by Paolo Denti, showing what different options there exist. So I guess we all know repair with tricuspid edge-to-edge repair, but also repair with annuloplasty. And then on the other hand, the replacement devices, so orthotopic replacement or then also heterotopic replacement with a placement of valves in the vena cava. Following that device parade, the session did build around two actual cases, live in the box cases that were performed. A first one on edge-to-edge repair and a second one then on replacement. And it actually was quite nice to see how during the discussion of these cases, the imaging especially and the pathology of the TR, you could see how you could match these devices we have available now to the patient and their anatomies. So the first case, the TEER case, was quite straightforward, addressable, good imaging, and they were able with two devices to reduce the TR significantly. The other case, however, showed a quadricuspid valve, so a bit more challenging. There also was some rheumatic component to the TR, and imaging was impaired by a MVR being in place. So there they decided to go for a valve replacement using Intrepid. And it went well as well, I can tell you. Yeah.
Okay, good. So we also had today on the late breaking, we also had two sessions for with clasp PR, two presentations with clasp PR, but also with annuloplasty. So it has been very rich in terms of repair, but also of replacement. So who convinced you more? What would you defend more?
Well, it's a good question. It's a key question probably. I think Neil Pham in the end summed it up quite well also in that session. Right now we have very good safety data for TEER. So also when asking the audience what would you go for, TEER was the way to go because it is safe, it is kind of reliable. However, replacement is catching up probably way faster than in mitral. And the easy and also abolishing TR solution of replacement might not be exactly around the corner, but in midterm might be doable and might be even more TAVI-like as we see on the mitral.
Okay, thank you. So let's move to the mitral side. Cara, what do you have for us?
Yeah, look, well, they certainly kicked it off from the start, I say, with the mitral sessions this afternoon. We really saw a tour de force of all the mitral interventions that are currently available now. So we had surgeons and cardiologists really discussing different valve anatomies for primary mitral regurgitation. And of course, at the moment, surgical valve repair is still really the gold standard there for the vast majority of patients, I'd say. The surgeons showed us some really fantastic demonstrations of some minimally invasive techniques, including robotic-assisted techniques, and minimally invasive endoscopic repairs, where patients are able to come in, have a keyhole procedure and really go home a few days after their surgery, which is fantastic to see. And they really wanted to highlight to us all that, you know, the expertise of the surgeons and the surgical team is really the important part in surgical repair. So they encouraged us all as cardiologists really to sort of hunt out those high volume centres so that our patients can get, you know, fantastic results. Turning to transcatheter edge-to-edge repair, obviously there's so much happening in this space and it's really growing in popularity. We've now got 6 devices across 2 companies for edge-to-edge repair, which can really tackle all sorts of anatomy. And I think for patients who are older, who are comorbid or maybe don't want to have a surgical procedure, you know, edge-to-edge repair is really demonstrating that we can deliver a quick, you know, at our centre we do day case procedures for our edge-to-edge repair for probably most patients, 80% of patients. They can have a quick procedure, they can go home the same day. It is very safe, the risk profile is favourable, and you know, the data coming out of the CLASP 2 trial really shows that these repairs are durable for our patients. And then we went on to sort of see what's happening in the mitral valve replacement space, transcatheter mitral valve replacement with the Tendyne valve, and also now the Intrepid valve. They showed us some really nice cases there. And there are a few new interesting things. So we saw a transcatheter neocord repair, which I hadn't seen before, in addition to transatrial neocord repairs. So I think there's a lot happening in this space, and I think, as Jonathan's really highlighted, it depends on the patient, the expertise in your centre, and you know, the anatomy you're dealing with. We've now got lots of options for making sure the right patient gets the right procedure and the right device.
Thank you. So maybe I will ask you the same question regarding repair versus replacement. I mean,
well,
if we had everything available.
I'm a TEER operator, so that's what I would go with. But you know, surgical repair is really excellent in this space, and if you've got a really talented surgical team in your centre, take advantage of them. But I think we're still discovering all the anatomies that we can address with TEER. I think we're still growing in that area, and we've certainly seen some fantastic results in some tough anatomies. So I think there's more to learn there.
Thank you. So you will keep an eye, I guess, on the 2 tracks for the upcoming days, and we'll have more and more news for you in the coming days. So now we will move to our next section, and we will try to give you an insight of what was happening throughout the conference, throughout the course outside. So we will have a short recording of hot topics that has been discussed.
So welcome PCR community, welcome to London, welcome to the XL, where we have 3,000 attendees for 3 valves. We have aortic, tricuspid and mitral here at ACURATE PCR London Valve 2022. My name's Heath Adams, I'm a cardiologist from Australia. It's my great pleasure to introduce Dr. Azim Lateeb from the USA. And today we're going to have a brief introduction about where the course is going. So Azim, what are you excited about being in London today?
Well, firstly, let me just say I'm so excited about being in London again. And it truly feels like this is post-COVID PCR, London Valves. I don't think we've ever seen so many people come to London Valves, not even before COVID. So to be back here with full rooms of real people, not just people listening to us virtually, is huge. I'm really excited about that. I mean, when you come to a conference, the ability to talk to your colleagues, to network, to enjoy that energy of what comes from being in a live conference is just incredible. So that's the first thing I'm most excited about.
Jafar, just tell us what you like the most about PCR London Valves.
Well, thanks, Heath. It's great to be back in London. Great city and great conference. And I think one of the key exciting things for me is to be here in person, and the key things that you get in the in-person conference, which are those sort of key highlight messages that you get that you don't really get in a virtual conference, right? You come here and you remember things when you see someone present a complication, you see something happening in a live case and you're there. You get that instant memory that embeds in, yes, and that comes to you later in practice. So I think those moments are what really makes the meeting.
Dr. Saad, what are your expectations going into this PCR London Valves conference?
I have actually few expectations, and usually, because I'm coming from a country that we have not so many interventions in cardiology. We have already started doing some, but I'm hoping to see so many different interventions that we do here, especially in developed countries, in Europe, in the UK in particular.
Great. And what sort of things are you hoping to bring back to Kigali from this experience, from this conference?
Mainly it's just an open mind to take back home and show people that there's a lot out there that we haven't achieved, and if we can open our minds to it, and we can actually do that. So cooperations with different companies and different cardiologists.
Welcome, Dr. Abdul Hafez. So you're presenting some fascinating data about CT in TAVI. Tell us a bit about that.
We're evaluating the coronary reaccess with ACURATE Neo2 using CT, which is something that hasn't been so far done. So we're looking forward to present the data. That's
fantastic. And are you using CT to predict success in coronary reaccess?
Yes, it actually seems to agree with the data derived from actual coronary access evaluation. So it seems to be a good step on the right way.
Oh, we'll look forward to hearing all about it. Hi, so I'm here with Leah, who's just been doing the TAVI escape room. Tell us, Leah, what did you do?
This was amazing. It was our first time with our team, a young team, and we were just trying to save an alien with an aortic stenosis, and we did it. Oh, fantastic. And we were also quite good. Yes.
Did you win? Did you come top?
Yes, seems like we're second, so wow. Unexpectedly, yes.
Oh, I'm very glad to hear.
Thank you.
Anything else that you're looking forward to doing while you're here?
We love the simulators. It's a very perfect, great, amazing, yes, amazing opportunity to try hands-on, and we also like the conference rooms and everything, but the simulations are the best.
Great, I agree.
Yeah.
Well, look, it's been great to talk and hear about the escape room, but we're now going to go back to the studio to our colleagues there.
Thank you very much. So now that you know everything about what's happening, almost everything about what's happening here at London Valve for this first day, we'll move to our expert interview. I have been joined now by Mohammed Abdel Wahab. Thank you for being here.
Thank you, Nicole. My pleasure.
So we'll want to give more insights to our audience to tell them more about what's happening outside. I mean, London Valve 2022, we are all here, it's fully packed, lots of people. What are your feelings and your first insights about the conference so far?
Yeah, I mean, I think really people are happy that they're back. I think more than 3,000 attendees, it's a new record, so we keep on breaking records. The 13th time in a row. I didn't realize that we started that long time ago with the Congress. And it's been evolving over the years. So if you compare the Congress this year with how it started, it's much, much bigger. And the tracks are so interacting, and people are really eager to learn. And you feel the pulse of the new generation that are coming and hopefully taking over in the near future. They are excited to exchange and to learn and to talk. Extremely international audience from all over the world. So it's not only Europe, but really international. And I think this signifies the role this course is playing now in the intervention community.
Absolutely. I was impressed to see how much interaction there was. People were chatting, raising their hands, standing up, and it's very nice to see this. I mean, this is supposed to be a course, not a lecture, and obviously there are very few lectures, lots of discussions and cases and practicals, so very interesting.
Yeah, I think the format developed in a fascinating manner, and it allows this interaction, and it reinforces the importance not only of people who are on the panel, but also all the people who are attending and participating. And I mean, we are one family, and we should be exchanging.
So what are your main expectations from this London Valve in terms of topics? I don't know if something was already presented or something is going to be presented. What for you will be the highlights of London Valve 2022?
Yeah, I mean, one of the highlights, it's not a topic, but one of the highlights is this new simulation training module that has been introduced. I find this extremely interesting, and I already got feedback from people who were very enthusiastic in seeing the new devices, not only seeing them and hearing about them, but really understanding how they can be applied, getting hands-on training in a very structured way. It's a three-step training module. You first see how the devices work, and then you apply them hands-on. And the third step is go and do specific training in the training village. So it's, I think this is really exciting. Regarding topics, I think there's a lot of attention, and this has been the focus of the last years on the mitral and tricuspid tracks. So they became as big as the aortic track, if one might say so.
Very fast.
Yeah, very fast, very fast. And people want to learn. And the nice thing about this is that, I mean, when we started doing valvular interventions, we used to learn from our mistakes. We didn't have the experience to build upon, and this is different now. And this again reinforces the importance of such a course, to share thoughts and share experience, because I think you're not forced anymore to learn by doing. You can also learn by sharing experience.
Absolutely, absolutely. Did you attend any specific sessions today? Is there some discussions you want to share with us?
Yeah, I mean, of course, a lot of important sessions. One session, and you cannot underemphasize the importance of the data we have this year from the protected TAVI trial in the TAVI field. The largest trial so far that has been done in structural interventions with 3,000 patients. Very interesting and important results published in the New England, and led to a lot of controversy about a very important topic, which is stroke prevention. And there was a dedicated session today in the aortic track on prevention of cerebral and even non-cerebral embolism. Very well attended, very nicely organized, and a very lovely discussion about the topic, about the data, of course, but also about the beliefs people have. And it seems, and what surprised me, people didn't lose their belief in our ability to prevent strokes. And I think this is important. We see stroke as a very important and limiting complication for patients. And we are still believing that we may be able to prevent it. Maybe not as powerful as we thought we could with this device, but people didn't lose hope. So people still believe that there's room for this technology, maybe to improve, maybe with more data, with larger studies. But I think it's important that we don't...
A nice selection, as usual, with the beginning of
a lot of factors, but it's important that people didn't give up the technology and said, okay, it doesn't work, so let's forget about it. It's not like that.
So let's move from London Valve 2022. I mean, I have an expert here. I would like to know, what do you expect from 2023? What for you will be the main topics that we'll be discussing?
Yeah, I mean, 2023, there are some developments that we might expect in the aortic field, particularly in expanding the indication of TAVI to other categories. There are a few trials running up in patients with asymptomatic AS, with moderate AS. Not sure whether we will see this in 2023, but this will remain an important topic. And we may see initial results in the next year. So expanding indications is one topic. I think in the tricuspid field it will be very important to see the data that hopefully will come up soon from randomized trials comparing interventions versus medical therapy. Because this may be a very important and revolutionary step in this group of patients who are extremely sick, extremely difficult to help, but if we have a signal that we're doing the right way, I think this field may even expand further.
So if we put ourselves in our scenario that we are already in 2023, you are my guest, we are at London Valve, are those the topics that you expect that we will be talking about?
Yeah, we will still be talking about training and how important training is.
Hopefully.
Yes, I hope so. I'm sure we will also be talking about a novel additional track that help people understand and get trained. I mean, the group is extremely innovative in its appreciation of the needs and the development of the Congress. It's extremely dynamic, so I think we'll be talking about new tracks as well. And maybe we'll be talking about the new trials we just mentioned as well, and their impact on praxis. What I'm also very happy to see is I think the number of surgeons attending the Congress is increasing as well. So I've seen a couple of guys that usually in the past didn't attend the Congress, but they're now attending, which is a good signal from one side, and it's also an appreciation of that we're doing the right thing. And a lot of surgeons are starting to think critically about their own congresses, and they want to adapt a little bit and get the interaction we're doing here at London Valves into surgical congresses.
It's funny because I heard the same from surgeons saying that maybe we are doing, each of us is doing his conferences in his own section, and maybe we should meld together. So maybe we are managing to build this heart valve team that we want to build, and that is written everywhere in here, heart team. So maybe the heart team is already here in London Valve. So let's see if our predictions go right, and if in 1 year we'll be discussing what we actually predicted. This is recorded, we'll be able to compare. So thank you for being here today, and I would like to thank our audience for staying with us throughout this live session. I really hope that we were able to transmit to you at least part of what's happening here. But I mean, what's happening here is really impressive. I mean, lots of attendees, lots of interesting sessions. And I really hope that with our live from London, we are able to transmit this. Stay tuned with us because there will be live from London again tomorrow and on Tuesday. And have a nice evening. Thank you.